We're about to start the GU Oncology session, and it gives me great pleasure to introduce our first speaker, Dan Vaena, who is GU oncologist at West Cancer Center and Research Institute and leads our phase 1 effort. Thank you, Dan.
Hi, everyone. Thank you so much for having me here today. Thanks, Brad, for inviting me once again to give this talk. So we're going to talk about prostate cancer. A little review of everything that's been happening the last few years, which has been a lot, and updates from ASCO GU that just happened last week. There's a lot happening in prostate cancer. So two major therapeutic spaces for this update today. One is metastatic castrate-sensitive prostate cancer. Those are patients who either present de novo with metastatic disease, or they had local therapy before, biochemical relapse, now they have metastatic disease. So the mCSPC has become the term that a lot of people use. And the second therapeutic space, castrate-resistant disease, mCRPC. For mCRPC, we're going to cover the issue about first-line therapy and the issue about homologous repair recombination abnormalities, which has been a big topic at ASCO GU this year. So just to introduce with a quick case so people understand what we're talking about here in castrate-sensitive disease. This is actually one of my patients, 67-year-old African-American man, presented to urology with microhematuria. PSA was 12. On urology exam, the DRE was unremarkable. The biopsy, all cohorts were positive for prostate cancer, so it's high volume disease, with Gleason 4 plus 3 equals 7 in some cohorts, and Gleason 3 plus 4 in the others, but essentially very high volume, high percent of each core, bulky pelvic adenopathy, and then extensive bone metastasis at presentation. And then we always look at comorbidities. We have a lot of options for prostate cancer these days, with comorbidities is one of the main things we always have to take into account to decide what's best for the patient. So this particular patient has hypertension and has cardiomyopathy with some diastolic dysfunction. So before ASCO GU this year, we already have a very extensive background of intensification of hormonal therapy for prostate cancer. So basically, we've had years now of multiple different trials suggesting that if we combine androgen deprivation, meaning lowering the testosterone level, which is ADT, with a variety of other agents that initially we had proof of benefit in the CRPC setting, all these trials brought all these treatments up front. Docetaxel with the CHARTED study and STAMPEDE, and eventually all the androgen, almost all of the androgen receptor inhibitors, as well as the abiraterone, all these trials were positive in the upfront setting. And there was an overall survival benefit with almost all of those. You can see on this slide, docetaxel, abiraterone, enzalutamide, and apalutamide. Now, the catch has been really, and the topic for ASCO GU this year has been the notion of the triplets. So the intensification of ADT plus docetaxel plus abiraterone was explored in PIECE-1, which was just presented last year at both ASCO and ESMO. And with PIECE-1, what occurred in PIECE-1 was that 60% of patients had received docetaxel. There was a trial amendment during the trial that added docetaxel to the abiraterone backbone. And it improved. There was an improvement in rPFS with docetaxel. And the data at that time suggested that there was a benefit in high volume disease with the addition of docetaxel and abiraterone. Now, the catch with that study was that it was exploring all patients were receiving docetaxel at that point that the trial was amendment. So the question was really about the addition of abiraterone to all patients receiving docetaxel, not the other way around. So this brings us to ASCO GU this year, and this year we had the ARASENS trial presented. So ARASENS was a triplet trial of the addition of darolutamide or placebo in addition to ADT and docetaxel. And so one of the main differences from ARASENS to all these other trials that I mentioned, including Enzamet with enzalutamide before, was that in ARASENS, all the patients had to receive docetaxel. So it was one of the cleanest studies as relates to the fact that all the patients are getting the ADT backbone and the docetaxel backbone, and then they have the randomized question of adding the AR inhibitor or not. And those were patients who basically had metastatic castrate-sensitive disease, and there was stratification between among the extent of disease. And basically, this shows the vast majority of patients having M1b disease with bone metastasis. Now, what this does not tell us is the differentiation between high volume and low volume disease, which is one of the differentiators in the charted data with docetaxel. However, based on the characteristics of this population here, it's expected that the vast majority of patients here would have had high volume disease. And what this trial showed was clearly there was a difference in overall survival, 62% versus 50% at 48 months, with favoring darolutamide. And there was an improvement also in several key secondary endpoints, including times to castrate-resistant disease, time to pain progression, and skeletal events, and which was not that significant there, but the time to subsequent antineoplastic therapy was quite significant. And this was well tolerated. There were no major surprises here. Darolutamide is already a drug that we've known to use in later line, and so there were no significant major surprises here, added toxicities from the darolutamide. And of course, patients can have the toxicities that we know can exist from docetaxel. So the question about a triplet intensification, there's several things that we know and we don't know about this, which makes this decision-making very complicated with the patients. So we've known from all the trials that I showed that intensifying with the doublet is very well established. So it's very clear today that if someone has metastatic CRPC, that they will do better long-term in terms of overall survival if we intensify their therapy with the doublet. And again, we have multiple agents that show benefit, and you can either choose docetaxel, you can choose hormonal therapy, and there's different practices in that regard, and you decide based on comorbidities. The data with docetaxel from the past seem to suggest that it's most applicable to patients with high volume disease. On the other hand, the data with AR inhibitors, the data from Stampede, for example, with abiraterone, and data with enzalutamide later, suggested that both patients with high volume of mets, low volume of mets would also have benefit. It's just the magnitude of benefit isn't that much with if you have lower volume disease, but there's also benefit with addition of oral hormonal therapy. And so, so this data that we see today shows us that both from PIS1 and from darolutamide shows that if we add either one of those oral agents to ADT plus docetaxel backbone, that we're improving overall survival. And this appears to mostly apply to high volume patients. Now, what we don't know is the opposite question, right? So remember that those trials were, the backbone was ADT plus docetaxel, and then you have the question, do you add the oral agent or not? So if you approach this in a different way, and you say, well, my backbone is ADT plus abiraterone, I already set up my mind that I'm going to give this patient, ADT plus a hormonal agent. And the main question that I have for this patient, this is an example, is am I going to add the chemo or not? Well, these trials did not answer that question. So we don't know if adding the chemotherapy to a doublet that includes hormonal agent is going to be beneficial or not. Those trials have not been done. It's unclear if those trials will be done. If we look at the long-term outcomes on the doublet, and I'm going to go back to one slide here, this very first one. So if you look at long-term outcomes with an oral doublet versus the triplets, it becomes very hard to sort out if long-term outcomes are better or not. As you can see, for instance, in the latitude data with ADT plus abiraterone, you have an overall survival that has a median overall survival of 53 months with ADT plus abiraterone. If you look at enzalutamide, for instance, with the ENZAMET study, you look at 3-year overall survival of 80%. And then if you, on the other hand, look at the data with Arasense, you basically have different time points where, this data that's being reported here is a 48-month data, so it's a slightly different cutoff point than, for instance, Latitude presented the data. So you have to sort of extrapolate the curves, which is immature data beyond that cutoff line there. You have to extrapolate to try to make comparisons from one trial to another. And you can also see that the median survivals, if you go to the median there, the median survivals end up being sort of similar. So I think it becomes very, very difficult to sort out with all these questions if a triplet is truly going to be beneficial. We're doing cross-trial comparisons, which is typically something that we recommend not to do. But in clinical practice, that becomes one of the questions. And then the other question, again, is the benefit going to apply both to high volume disease and low volume disease? The suggestion seems to be mostly high volume. And then the other question is the benefit is going to apply to de novo versus recurrent disease. The patients with super high volume disease tend to be the de novo patients because the patients have recurrent disease after local therapy. Those are patients that are typically being followed. They're being followed by the urologist or the radiation oncologist with PSA. As the PSA starts to go up, imaging gets done and so forth. So there's a greater trend to finding low volume disease if someone had local therapy before. So again, most of these data probably will apply mostly to the de novo patients. But all this, I think, is very exciting. Definitely there's a lot of talk now about triplet intensification, but I think the decision-making needs to be highly individualized based on patient comorbidities. The patients need to be told these data probably, but that there's a lot of questions that we still don't know about that question. So moving on to CRPC now. So with CRPC, there's also, more than a decade of advances, almost 2 decades of advances now in improving outcomes in metastatic CRPC, initially with chemotherapy, later with androgen receptor inhibitors and abiraterone post-chemotherapy, later pre-chemotherapy. And one of the landmark trials there that's going to help our discussion today is the Cougar 302 study, which was done several years ago now. And that study was looking at abiraterone pre-chemotherapy. It was abiraterone plus prednisone versus prednisone alone pre-chemo. And that study had survival benefit. There was some crossover, which made it difficult to interpret, but there was a clear radiographic pre-survival benefit led to the drug approval. The reason I'm highlighting there in red the radiographic pre-survival, that's going to be one of the key benchmarks that we're going to use for our later discussion just a few minutes from now, which is how do we reconcile these data with what we're seeing now. So if we look at all these patients, again, this was before germline testing, somatic testing. This was like 10 years ago. Radiographic PFS, a median 16.5 months, so remember this number. And then what do we know about homologous recombination? So this is now what these 2 trials I'm going to be presenting have to do with BRCA and genetic testing and so forth, somatic abnormalities. So what do we know about those patients, that subset? So we know that about 20 to 30% of metastatic CRPC patients have homologous recombination of either germline or somatic. They're not mutually exclusive, so the testing for one doesn't exclude the other. So germline will be approximately 10% of patients. Somatic will be approximately 15 to 20%. So you sum them up, you get to 30% or so. We know that patients who have HRR, especially BRCA, they have a worse prognosis. Now, that's a kind of a mixed bag, very difficult to understand the natural history very well exactly in which therapeutic space does this apply to. So we know that their overall survival seems to be worse. We know that we think that they may present with higher Gleason scores. They may present earlier in life. They may progress faster to hormone refractory disease, perhaps. The data that applies to the discussion today, the comparison or the background is sort of this data in CRPC. So are their CRPC outcomes worse if a patient is BRCA positive natural history-wise? So that data from, for instance, the PRO-REPAIR-B is the study I highlight there, showed a decreased cause-specific survival. So the cause-specific survival with patients who are BRCA, I think BRCA2, was lower, just 17 months. Cause-specific survival if they were BRCA2 positive, different than higher if it's a non-BRCA patient. So That is a factor. And then we have the olaparib, rucaparib, niraparib data, all these PARP inhibitors. Now olaparib and rucaparib being FDA approved right now. Olaparib based on a phase 3 trial, which was profound. Rucaparib phase 2 data with Triton. But basically, all these drugs so far until now being examined in the post initial therapy setting. So initially, patients with CRPC getting typically an AR inhibitor or abiraterone, and then upon progression, getting those PARP inhibitors. That's been the approval so far. Olaparib is approved in that space. Rucaparib was approved after both prior AR therapy and a taxane. But if you look at the olaparib as a classic example, you get a radiographic progression-free survival of 7.4 months. And this is, again, post-ABI or ENZA. So just, again, before we move to the next slide, if you look at the top, you see an RPFS of 16 months until patients progress on ABI, and then you would see a PFS of 7 months. So if you add 16 plus 7 is about 23. Now, this is really not appropriate in the setting to add those on because the natural history of all comers may be worse if this is a BRCA population. So I have all these nuances about natural history embedded in this discussion. Which brings us to 2 trials that were presented at ASCO GU this year. One was PROPEL. So PROPEL was olaparib combined with abiraterone versus placebo and abiraterone as first-line therapy for mCRPC. So these 2 trials I'm going to present very different from each other in the way they were designed. So olaparib plus abiraterone trial was for all comers. So they took all comers CRPC patients. They did somatic testing on those patients. A lot of the somatic testing is at the bottom. It's in small fonts. You may not be able to see it. I'm sorry about that. But a lot of this somatic testing was based on ctDNA. There was some tissue that was allowed. I'm not totally sure how much. But a lot of it was based on ctDNA. And basically, the endpoint was RPFS. That's a well-established endpoint in prostate cancer these days. And highlighting that they found out which patients had HRR after the fact, right? So patients get enrolled, they get ctDNA testing, and then it's known after the fact. And you can see in both arms was about 30% of patients had HRR. Again, this is based on ctDNA testing. Approximately 30% of those patients had homologous recombination. And this was a positive trial where this is the investigator assessment RPFS endpoint, has a difference there in the median RPFS at 24 months, 24.8 months in olaparib ABI versus 16 months placebo ABI. Remember, this 16 months is exactly the same 16 months that we had seen with the Cougar 302, so it matches there. This is, again, independent center review, very similar numbers. And then this is important in the subgroup analysis. If you look at the bottom, if you have HRR status, and you can see that both the patients who had HRR abnormalities or mutations in the HRR genes, typically BRCA, but there were others, versus non-HRR, they also had benefits. Both of them were, better than abiraterone alone. And it's hard to interpret the subsets, but basically the notion was that this was a positive trial and it did not matter that much if you were HRR or not. The overall survival is still immature, so we can't comment on that. And there was a benefit in PFS2, which is shown here as well. And the response rates were a little bit higher if you had olaparib abiraterone compared to placebo abiraterone. And it was overall, safety profile was overall tolerable, did not add that much toxicity. So then the other trial that was presented was Magnitude. And Magnitude is a very different trial. It was with niraparib, so different drug, PARP inhibitor as well, different drug, but also with abiraterone. But it was different in the sense that the patients were pre-selected and they were randomized differently if they were known to be HRR positive or not. And you can see here that stratification is completely different, and they go into different arms, and the questions that are asked are different, and the design of the study and the power of the study is different with different endpoints. What was seen was that for the unselected patients, there was no benefit. So this was niraparib plus abiraterone did not make a significant difference. Now, if we look at the patients who had HR abnormalities, we can see again that this is a slide I put in here mostly to show you that there were several different genetic abnormalities. Most of them were BRCA2. And there was a variety of other smaller abnormalities, which is going to lead to a lot of discussion in the years to come, because there's a lot of uncertainty in prostate cancer if those other abnormalities also respond to PARP inhibition or not. But basically, what was seen in the BRCA mutated subset was that there was a significant difference in RPFS, both by central review and by investigator, if they had niraparib combined with abiraterone. Now remember, going back to Cougar 302, and going back to PROPEL, the first study I showed, that the median RPFS in the control arm with abiraterone alone had been 16 months, both in Cougar and in PROPEL. And here you have a median RPFS in the control arm, which is just 10 months or 12 months. So the question is this what we're seeing here simply the natural history of the BRCA patients that have a more aggressive natural history and are, we're essentially normalizing their RPFS to what we would expect with Abi alone if they didn't have BRCA? Or was this some kind of skewed patient population that, for whatever reasons, we don't understand? But definitely a positive study for RPFS, as is shown here. And this was for all homologous recombination patients. This was for BRCA-only patients. This was for all mutation patients. And you can see there was a benefit as well. Although the benefits wasn't so striking, again, speaking to the fact that it appears once again that the best patients for PARP inhibition are the ones that have the most benefit are the BRCA patients. But again, once again, the overall survival is immature in this study. And there was a slightly higher response rate with niraparib. So again, what we don't know, and that's a very complicated slide here. So what we know is that the radiographic progression-free survival benefit with olaparib was seen. This was in unselected patients, and it appeared to be both in patients who actually had the mutations and did not have the mutations. Now, notably, this was done a lot by ctDNA, so we don't actually know if this was all done on tissue. Some would say that it's possible that there were more BRCA patients here than is realized, and that the benefits that we're seeing are because there's more BRCA patients that we know. Now, that being said, the frequencies of abnormalities that we're seeing here were comparable to other studies, to what we knew, what we expect in this general population. So it does not appear to be significantly skewed that way. And then we also know from magnitude that there was a benefit with niraparib in HR patients, but that the abiraterone patients alone had a median RPFS that was lower than what we know before, but it could reflect their natural history. And that there was no benefit of niraparib if patients did not have the mutation. So it becomes very confusing. Why does olaparib help all patients, and why does niraparib doesn't help all the patients? So what we don't know is that, first of all, we don't have overall survival. So this is very important to know in this field, because those drugs are available. They can be used sequentially. So it becomes the question, would sequential be just as good? Now, we're not suggesting that would be just as good. In prostate cancer, there's a very long history. The last 5 years, all these trials of bringing drugs early have shown us consistently that the sooner we do things in prostate cancer, as a general rule, the longer their survival has been. It's unclear if it's because the treatments are really better if used early, or if because just patients may perhaps not have access to those drugs later, or their performance status ends up declining. Whatever reasons, we don't know, but the fact is that intensification up front in prostate cancer in the last several years has always generally been a positive thing. But again, we don't know if the sequential approach here will be just as good. If you sum up, again, things that you should not do on trials, but if you sum up the rPFS with Cougar, with the rPFS with niraparib and olaparib, post-abiraterone as an example, those numbers end up being sort of similar. Again, things we shouldn't do, but when taking care of a patient, those are things that will come up in discussion. And then the question, did the niraparib control arm underperform, or does it just reflect the prognosis of BRCA patients? And then obviously they're different drugs, so they're different drugs, but they're sort of not different drugs, right? Both of them are PARP inhibitors, and so, you know, are those differences between olaparib and niraparib so significant that they would explain the results that we're seeing? We just still don't understand the answers to that question. And again, could there have been more BRCA2 patients in PROPEL that we just don't know about? Doesn't appear to be the case, but that's where we are. So I think in summary, it's very confusing. I think this data is premature, is not ready for prime time. The gold standard here would be overall survival. We don't have that data. There's a lot of confusion, so I don't think this is ready for prime time. I'm not ready to use these combinations for my patients yet. They don't have FDA approvals for that yet anyway. But the importance here is that testing for HRR becomes more and more important in prostate cancer. That's become very, very clear. The study so far suggests that there's a lot of people who are not getting HRR when they should be getting. The numbers I've heard, about 20–30% of patients only getting somatic testing, germline testing, rather than most patients should be getting that. So if you can take away any message from this talk today, remember to do molecular profile, remember to do germline testing. They're not mutually exclusive. Thank you so much.